thanks everybody for coming along on what is a lovely evening outside. So I'm glad you've actually come along and not just used this as an excuse to tell your spouse you're coming to the lecture and actually go to a pub garden instead. So thank you for your, for coming along. So basically, this kind of first lecture, I wanted to talk about sort of regenerative medicine in canine orthopedics. It's something that is on one hand incredibly complex and on another hand relatively simple. There's a lot of kind of misunderstanding about regenerative medicine, so kind of wanted to try to give you a little bit more detail about what it is and also what it isn't, and also how we use it here and how you can use it for your cases, and we can use it for your patients as well. So if we were to say, what is regenerative medicine? Well, it's basically using biological agents to kind of repair or replace damaged tissue. And effectively, what it is aiming to do is try to kind of modulate healing. And I'll go through a little slide a little bit later on to kind of explain in a bit more detail what that is. One of, I guess, the kind of key things is that it's not something that is going to cure problems. And sometimes people think it's going to be this kind of magic solution that a dog has arthritis, we give them some stem cells and the arthritis goes away. It's not going to do that. And effectively, what they're mostly going to be doing is reducing things like inflammation, promoting regeneration of cells, and also kind of improving some structural integrity. So we'll kind of run through some cases. And it's kind of given this phrase regenerative medicine, but you can maybe think of it as more kind of reparative medicine. The fact it's going to repair tissues, maybe rather than sort of regenerate and suddenly grow a new leg or something along those sorts of lines. And when we talk about regenerative medicine, we sometimes then also use this phrase kind of orthobiologics. You might come across that phrase, which again is using biological agents for orthopedics. And there's lots of different ones that are available and exist, but primarily we're going to focus this evening on PRP, which is platelet-rich plasma, and also stem cells. They're generally the most kind of common two that used in veterinary kind of canine orthopedics. They are the two that we predominantly use here. So we're going to kind of focus mostly on these. So what are these? What is PRP? So PRP is whereby if we were to take a sample of blood at the end, put it in a centrifuge, and we can spin it down. And depending on how fast we spin it and how long we spin it, different cells will sort of spin down at different rates and therefore form at different depths. So like when you are taking a blood sample and running a hematology biochemistry, you might be sort of separating out different bits from the blood. And this is what we do. And what we're interested in is the plasma with platelets in. So what we are aiming to have with PRP is a high concentration of platelets relative to blood. And we're also generally aiming to reduce the white blood cell count. So we kind of want to get rid of the white blood cells and have lots of platelets. Now, you will come across other types of PRP that actually they try to have higher levels of white blood cells. But we're not going to go quite into sort of the complexities of that this evening, but we're going to focus on PRP. So in terms of platelets, why are we interested in those? You often think platelets are there to make blood clot, and that's one of the main roles that they have, but they also have some other roles that they play. And one of the key things is the alpha granules. And there's lots of complex terms and lots of acronyms. It's a bit much to go through in an evening after a busy day. So we won't go through those in too much detail, but these are some substances that are contained within the alpha granules of platelets. And these are the things that what we want to utilize and help us. So what they are going to aim to do is to help kind of orchestrate the healing process. So whenever we are healing, there is inflammation to an area. The body sends in the substances that it has to help tissues to heal and reduce pain. And we're trying to take those to enhance healing of tissues. And we do that by putting blood in a centrifuge and then concentrating down to get our platelets. And most of the time, this is autologous. So it comes from the individual dog. So we take that individual dog's blood and then spin it down and reuse it for that individual patient. And then we don't have to worry about sort of cross-contamination of any diseases or any potential reactions. So we predominantly take it from the individual dog themselves. Now, not all PRP is the same. And this can make it quite a challenge, because if we're trying to compare results from one study to another study, if they've used different types of machines or different equipment, then we can have different PRP. We're injecting different things. So it makes it really hard to kind of compare. And also, we don't really yet know what the perfect recipe is. How many platelets do we want? Do we want a bit more white blood cells? Do we want other things? So there's lots of studies done trying to look at kind of different levels. And therefore, depending on who produces your PRP, you will get some differences. And this makes it a little bit difficult in terms of publishing studies and research and having sort of comparisons. And we'll mention that a little bit later on. So as an example, predominantly we're looking at platelet-rich plasma, but you can also have things like platelet-poor plasma. And then some companies will actually name their PRP something slightly different to try to sort of differentiate it. So I'm a sort of education consultant for Arthrex, and I've borrowed a couple of their slides. So they call theirs, for example, ACP. It's basically a type of PRP, but some companies will name things slightly different. So you might find this a little bit kind of confusing and, again, harder to kind of compare. They're effectively types of PRP. There is some evidence and more that's coming out suggesting that it might actually be in part the number of platelets that's important. And therefore, the more platelets that you have, it might be that you get kind of better results. And you might have come across some people recommending having a course of PRP. So rather than just a one-off, maybe having a series of injections, often maybe, say, 3 weeks apart, and maybe having a course of 3. And again, from veterinary studies, there's not a lot of studies, so it's hard to know whether that does definitely make a difference. But there are some studies in humans that suggest that, again, having this course can be helpful. And then, because it can sometimes be hard to schedule repetitive injections, say particularly if you were trying to do this, on the NHS and have people come back for sort of 3 repetitive injections, it might be that giving more platelets in one go is then going to be an easier thing to achieve. So one of the ways in which some suppliers are going is to try to concentrate a bigger number of platelets in one go. What that potentially means is taking more blood, which from a human, we kind of are quite big, we have lots, but from small dogs and cats, sometimes that can be a little bit harder. So we do need to be a little bit careful as to how much blood that we take. And if you are thinking about having your own centrifuge to do PRP in your practice, maybe need to have a little think about the size of patients you might have and how much blood you need to take. So one of the advantages is we're able to actually do it with a very small amount. We bought a very specific centrifuge, so we can do it with a small amount. So we can do it for cats and small dogs as well. So how does PRP work? What is it trying to do? And we talked about these alpha granules, and what it's aiming to do is to try to reduce some inflammation. And we often think of inflammation as being purely a bad thing, but as we mentioned, inflammation is also how the body tries to heal. So if you have a trauma or an injury, everything swells up, you get lots of inflammation. That's trying to help the body heal and provide some pain relief. So what we're aiming to do with the PRP is have more good inflammation and less bad inflammation. And it's going to enhance then the proliferation of cells. So cells to develop and multiply to help to heal. You can do this thing called chemotaxis, which is where it attracts certain cells to come to that area. It can help cells to differentiate and help new blood supplies form to areas, which is again going to further help heal. So in terms of what's out there in the literature, people often ask, what studies have been done for things like stem cells and PRP to sort of show that they can have an effect and that they can work. So if we kind of look specifically for studies in dogs and looking at osteoarthritis, there was this study that came out and they compared either having steroid and hyaluronic acid combined, injected into elbow joints, versus having PRP injected into joints. And generally, they saw that dogs that received either of these did improve. But the dogs that had the PRP were doing sort of better around about sort of the 6-week mark in terms of their sort of lameness and pain scores. So it did show that PRP was helpful in improving lameness in dogs with chronic elbow osteoarthritis. So as well as using it for osteoarthritis, we can also use PRP for soft tissue problems or musculotendinous problems. So if we are using PRP for tendons, we're using it to try to promote some improved collagen architecture and also the blood supply to the area. So what can happen in soft tissue problems? So for example, muscles and tendons, the tendons can have really poor blood supplies. So it's really hard for the body to get all of these healing substances to that area. But by taking PRP, we're sort of taking it, concentrating it, and applying it to the area that needs it. And I'll give you some examples a little bit later on, but particularly for sort of chronic tendon problems, the body starts to kind of give up in its healing. Initially, you have inflammation, and then it sort of starts to give up, becomes quite degenerative. We sometimes used to call it tendinosis. So we used to say tendinitis was the acute bit. Tendinosis was then this progressive degeneration. Now I tend to just use the phrase tendinopathy because it's kind of a sequence of events rather than two separate identities. So often the body starts to give up healing, and then we can try to use PRP to kind of restart that healing process. So it can be useful in sort of chronic musculotendinous conditions. Most of the studies that have come out using just PRP have actually been more papers whereby there's been more of an acute trauma. So there's one study in Achilles tendons whereby the tendons were ruptured and repaired, and then a type of PRP was used. And then also done something similar recently and used PRP in these particular cases to help with their Achilles tendon healing. So this was a paper that we published a few years ago now. And what we did is we looked at lots of cases that we were using PRP for and tried to compare to see with patients of different ages, different breeds, were we getting different quality PRP? Were we able to get enough cells to use? And basically, I suppose that the takeaway was, regardless of the patient's age, gender, breed, or weight, we were able to get a sufficient number of platelets from their blood samples in order to use for PRP. So it is something that perhaps there was a thought that, you know, maybe younger dogs it would be better to use, would get better PRP, but we can get it in older patients as well. And regardless of the size, we can still get a good number of platelets. So the next thing then is stem cells. And what are stem cells? So stem cells are a cell that is quite early on in the sort of development of that particular cell. And it's at a stage whereby it can change into different types of cell in order to help those areas to heal. And when we are using stem cells, we're predominantly using mesenchymal stem cells. And basically, this is the types of cells that form the building blocks of lots of tissues within our body. So if we have a mesenchymal stem cell, we can use it to help with multiple areas. And we're potentially able to manipulate that cell in order to go more towards one of these areas. So we'll mention this a little bit later on. And I'll mention it now, but this is also potentially important because what we'll talk a bit about later on is how we get stem cells and where we get them from. And if we are using them to help with muscles or tendons, then we want them to be mesenchymal stem cells. If we're using them for joints, for things like cartilage, we want them to be mesenchymal stem cells. So if we're going to get them, we need to get them from one of these areas. So we'll talk about where we tend to get stem cells from, and that's the reason why we tend to go for particular areas of the body. So the cells are essentially kind of multipotent, so they can change into multiple different types of cells. And I've put up this little orchestra image here in the conductor, and the reason is this is quite a nice way to explain what stem cells do. So we mentioned this a little bit for PRP. Stem cells are able to kind of orchestrate the sort of healing process in regards to trying to cause more good inflammation and less bad inflammation. And stem cells tend to have a relatively short-term effect on the cells that are there, in so much as if we inject stem cells, they don't stay around for ages, and they tend not to necessarily integrate a huge amount. But what they tend to do is affect the cells that are already present. So it's kind of almost like a hit and run. They're kind of there for a short period of time, but they then cause these long-lasting effects. So in terms of stem cells, we can get them from different areas of the body. And the one that we most commonly tend to use here is adipose-derived stem cells. So adipose tissue is fat, and we're either taking this perhaps from under the skin or from the falciform. So if you think back inside the abdomen, that little sort of falciform fat that you have just after the xiphoid next to the liver. So it used to be that the falciform was kind of often the go-to place to take fat to produce stem cells. And it does have some advantages, as in regardless of perhaps how skinny or lean the dog is, dogs will always have falciform there. So it's quite repeatable that you can go and get fat from that area. And there were some thoughts as to maybe perhaps was the quality of stem cells you got better from that particular area of fat. But the problem is you need to actually go into the abdomen in order to do that. So again, it's going to be generally quite low risk, but if you were to get an infection and suddenly have a septic peritonitis, that's quite a big thing a problem to have. Or if you had an issue with herniation or any strangulation of the intestinal organs as you were suturing things up, that could obviously have quite severe consequences. So we started to look at areas from subcutaneous parts of the body, and that's where we more often now tend to take fat tissue from. So some advantages of using fat is that lots of patients have lots of it. So we can often take a large amount, and it's something that they don't need. So it's going to have less side effects from taking it. And the other area that we will, that's often used to take stem cells from is bone marrow. And therefore taking fat just under the skin is a bit less aggressive, less painful than having to core inside a bone in order to get bone marrow out. Now, in terms of taking adipose, because we can typically take large amounts of it, it's often used when we want to do something called culture expansion. So what we mean by culture expansion is, as adults, we have very few stem cells. So even if we take lots of fat or lots of bone marrow, we'll still only have a relatively small number of cells. But what we can do is then we can culture those. So just like we would maybe kind of culture bacteria and the bacteria multiply, we can culture the stem cells so they multiply. So that means whenever we do an injection, we're injecting millions of them at a time rather than tens or hundreds of them. So you can use it in something called a minimally processed form, whereby you can take the fat, effectively kind of mush it down and take out the stem cells that are there and use the stromal vascular fraction and then almost inject that straight away. But most of the time we're doing this thing called culture expansion so that we can then have much, much greater numbers so that we can inject large numbers. And the other thing that we can do is once we have the stem cells is we can then store them. So we're able to allocate them into lots of small little pots and store them. So they're frozen in liquid nitrogen. We're very lucky that we actually can do that on site. So we don't have to worry about the stem cells going off to a laboratory and getting lost in the post or defrosting in transit. And then it means that we can use them again in the future. So you only need to take the fat tissue once, and then you can use it again for years to come, doing repeat injections. We just defrost it whenever we want to give another injection. So it can be very useful if we are having a chronic condition and we think we're going to use it to help a chronic problem, such as osteoarthritis. So I mentioned about these different areas that you can take fat tissue from. So we started taking some fat tissue from the flank area, so the love handles, And we then compared the fat that we were getting from that area to the falciv form. And we looked and we saw that generally there was no difference in the quality of the stromal vascular fraction. So there was no difference in the stem cells that we got. So it meant that we could perhaps move away from kind of going into the abdomen and taking areas from underneath the skin. And this is the little slide that was published in the paper showing that there was generally no difference in the cells that we had. Now, if you've actually sent any cases to us recently and we've taken stem cells, and particularly if it was me that did it, you might see that I haven't gone from the flank, I've gone from a slightly different area. So I had an idea of taking fat from a different part of the body. And I presented this at a conference last year, which is why it's got that bit at the top. So the reason for this is a lot of the time we use stem cells, we're using them for elbows because we see so many dogs with elbow problems, we can't cure their elbow problems, and they're often needing to have long-term management. So we're often in theatre doing arthroscopy to help treat their elbow dysplasia. And most dogs who have elbow dysplasia typically have it in both elbows, and we're often scoping both elbows at the same time. So this would be our setup in theatre, and this would be how we would put in the arthroscope in order to have a look inside and then take away any fragmented coronary processes. So if we know that elbow dysplasia or developmental elbow disease can't be cured, we might want to be thinking about options that perhaps could help reduce inflammation in the joint, try to give the body the best chance of trying to heal itself as best it can. The body's always trying to heal. Arthritis is always trying to destroy the joint. There's always this balance. We can't stop the arthritis, but maybe the stem cells can help. We can consider taking fat tissue at the same time. And particularly if the amount of cartilage wear or arthritis is a bit more progressed inside the joint, then we might know that keyhole procedures alone aren't going to cure the problem, and we might need other forms of management, which could then be following up with injections into the joint. So what then started to do was, if this is the position that the dog is in when we do a scope to both elbows, they're sort of laid on their back, and then we drape them with their legs out either side, is we could clip a little bit of the fur in the middle and drape that area. We can then do our arthroscopy as normal. And then I found that dogs always seem to have a little area of fat just in front of their manubrium, so just in front of the first bone on the chest. And what we can do is then make a little incision, maybe about 1 inch or so long, and we typically have always found that there is fat there. Even if it's been perhaps a really lean dog, so far we've still always managed to find that there is some fat tissue. So we can then take out our fat and then close up the incision. We generally don't necessarily need to always take quite this volume of fat, but it's always better to have more if they've got it available, just to make sure we definitely get plenty of cells. But so far, not had a problem whereby we've not been able to get enough cells from fat tissue. And then even if we're not doing elbow arthroscopy, I still now go from this same area. So we can just do a little clipped area in front of the chest, a little incision, and take our fat tissue. I kind of sort of collected some data over kind of 3 years. There was kind of 39 dogs. And in terms of conditions that we were treating, you can see the main one that we were using stem cells to help manage was the elbow joint for those cases. I think there's now maybe over 60 or so taking it from this area, and you know, well over 100 cases that I've done, and more that the team have done. And of, say, those 39 dogs, 30 of them were having some form of procedure done at the same time. 27 of them were having arthroscopy done to take out a fragmented coronary process. 2 of them had a sliding humeral osteotomy. And then 1 dog had a CUE put in, and we used the stem cells for the opposite leg. That wasn't quite as bad as this one. And we used it for the opposite side. And yeah, in all the cases, we're able to get enough fat to produce stem cells. Only real kind of complications are perhaps a little bit of swelling or seroma, and generally that will settle down by itself. There was 1 dog that maybe had perhaps an infection. It was a bit kind of not clear when they kind of contacted us. They said that the local vet thought there was an infection, gave them something to apply to it, when we asked the local vet, they said we couldn't see anything on our notes saying that there was a problem. So maybe it had an infection, but generally very, very low risk of having problems. And we started to compare the cells again to what we had in the other paper, and again are seeing that the stem cells that we're getting are equally as good. So you might find that if you send a case to us, that's where we're taking the fat from, and that's the reason. So possible downsides, I thought, were, well, it can be a bit hard to know if your dogs definitely have enough fat there, but so far it seems to be okay. We need to be a bit careful about seromas, so the dogs don't end up looking like this, but generally we're fine. And because we're coming towards the cranial aspect of the chest, it's kind of not actually lying on that area. So the way the sort of sternum curls up, we're kind of just going in front of that, so they're not directly lying on their chest when they are lying down on the floor. And yeah, it's kind of a safe area, even for us orthopedic surgeons. We need to be careful about things in the neck area, that we're not cutting any of these long tubes and that pulse or look white or air goes up and down in, but we should be pretty safe. So yeah, we found that generally we're always getting sufficient number of fat. Stem cells are good quality. It's useful if we're doing kind of elbow surgery because we don't need to change the patient position. We don't have to clip big other areas of the body like the flank or the abdomen, and it can all be draped in one area. And then a couple of other nice reasons is that the scar is generally sort of hidden away and it's kind of on the midline rather than the flank. And it's an area that they can't lick and they can't scratch. So if you can be a vet and do a surgery and tell the client they don't need to wear a collar afterwards, then you're probably the greatest vet they'll ever know. So that's another nice little advantage of that area. So if we were to do stem cells, this is frequently what we will do. But there are other options, and we can offer other options as well. So the other type of stem cells that you might come across is BMAC. So this is where we take bone marrow, and bone marrow naturally has higher numbers of stem cells. So there will be more stem cells in bone marrow compared to fat. This tends to be used more if we're then not doing that culture expansion. So we're just trying to use the number of stem cells that are present in the bone marrow, but not multiplying to get millions and millions. So what I tend to find is if I listen to vets around the world who are using stem cells, the ones who perhaps tend to use this a bit more tends to be perhaps vets, say in America, somewhere that's really big and it's really hard for people to come back and forth. So they kind of want the dogs to travel to an area, have everything done in one visit, rather than having to then go back again a few weeks later once the cells are being culture expanded. So because the UK is a bit smaller, it's generally a bit easier for people to come back and forth to us. And often, again, if we're treating sort of chronic conditions like osteoarthritis, they're perhaps going to want to use cells later down the line, so we can then sort of store them. But we can do this as well, and whereby we can take some bone marrow. So you can either take bone marrow, like if you were doing a sort of bone marrow aspirate, typically kind of going into the femur, so you kind of go down in the top of the femur. Or sometimes if we're in the middle of surgery, we might have a bone that we've cut, and we can then access the bone marrow at that time. So, for example, the sliding humeral osteotomy procedure, sometimes if we are cutting the bone, we can take a little bit of bone marrow from that area, or the top of the humerus is a big area, you can get lots of bone marrow. We can actually take a little piece away. Then we can give that to our regen lab team. They can actually start processing it as we're finishing the surgery, and then before we finish, they can bring us the stem cells ready and then inject that at that time. So we have lots of options that we can offer. So what are the advantages of stem cells in osteoarthritis? Well, they sort of down-regulate MMPs and other inflammatory cytokines. They can sort of promote cartilage synthesis. And in terms of improvements, this can vary a lot. And I'll give you a little bit about my experience, but typically we might be saying you can get improvements from, say, 2 to 18 months is what's sort of reported in some of the studies that have been published. The results can vary a bit, and I'll run through that in a bit more detail. And as we mentioned, they tend to affect the cells that are present rather than necessarily thinking about them integrating and staying there for a long time. And it's generally better to use them kind of earlier in the disease process. So we definitely see that the milder the osteoarthritis is, the more beneficial effect that we tend to get from using them. So if we were to do a little look at the literature in terms of what has been published using stem cells in dogs. So this was quite a good study in so much as it was kind of double-blinded and a placebo-controlled trial. And what they were able to see is in terms of success rate, so in terms of improvement in outcomes, that was greater in the cases that had stem cells compared to the placebos. This was just a single injection, and they kind of reported no adverse effects, so no side effects to having the injections done. And in regards to the force plate analysis, there was improvements in the cases that had the injections, particularly around the kind of 1 month mark is where it was more statistically significant. This was also another study that, again, nice in terms of study design, being prospective, randomized, and placebo-controlled. And this was a larger number of dogs with osteoarthritis of different joints. These were injected with stem cells, and then the dogs were assessed around about 2 months afterwards. And what we saw was that the dark black ones are the ones that were treated compared to the controls. And in regards to the sort of vet assessments and client assessments, there were notable improvements. And then this was our own publication that we published, whereby we, again, followed up our cases. So generally every single case that has stem cells or PRP, we're tracking all the data on these guys. So we're actually getting them to be walked over the pressure mat walkway, so we can kind of get objective data. And we're generally doing sort of follow-up kind of questionnaires for clients, and we're also assessing the patients and then logging all of the cells that we're using, so we know exactly how many, or near enough exactly how many cells we're injecting into the different joints and the different volumes, so we can kind of track all of this data. Because what we want to do is try to make sure that we're using something that is showing to be having a positive difference, rather than just using it. We want to sort of back it up with evidence and science as well. So what we were seeing in dogs that were injected with stem cells for osteoarthritis, we again could see improvements in their weight bearing. So compared to before injection to 12 weeks to 24 weeks, we're seeing that their sort of lameness and assessment, their kind of COAST score was improving. So lots of kind of positive things. We might be thinking, how effective are stem cells and PRP if using them for osteoarthritis? And it does vary from dog to dog. And it can be a bit frustrating sometimes trying to predict the future. We don't have great ways of predicting, yes, this dog, you're definitely going to see a big improvement, or maybe this dog is only going to be a small improvement. Definitely, I would say that the less severe the osteoarthritis is, the more likely we are to see a bigger improvement. And the way I perhaps try to describe it to families who come in with their dogs is that if we imagine kind of a grading scheme, whereby you can almost think of it as like a lameness grading scheme, where perhaps 1 is kind of mild and 5 is sort of severe. What we tend to find is that the stem cells or PRP moves them up perhaps 1 rung of that ladder. So if you had a joint that is horrible, it's not going to suddenly be excellent. It's going to maybe be sort of less bad in terms of how clinically affected the dogs are. And in regards to mentioning stem cells and PRP, just to kind of either confuse things or maybe to simplify things, most of the time when we use them, we actually use them together. So if we're doing stem cells, we're usually always adding in PRP as well, because all of those cytokines and growth factors from those alpha granules that we started off with, they're all synergistic for the stem cells. So we typically tend to combine those at the same time. So we will have our stem cells that perhaps have been culture expanded and frozen and stored, and then they're defrosted, ready for the day the dog comes in for its injection. We take a fresh blood sample at that time to have fresh PRP, mix the two together, and then we can inject to get the benefits of both in one go. So in terms of, I guess, a little bit of a summary, as you see, they're not perhaps this kind of miracle wonder thing that sometimes people think they can be. But in terms of evidence that we have, the strongest evidence is for osteoarthritis, where we do have some level 2 and 3 studies showing improvements in both pain and function. In terms of using them for tendons, the data is kind of promising, but there's still going to be more studies coming out on this. In terms of a lot of the data, there's generally a lot of kind of, say, smaller patient numbers, smaller study numbers, rather than huge studies. So it would be nice to have more studies and kind of more evidence. And a lot of evidence is also kind of coming from other species as well. But there is some studies from dogs, which is great. And it is often hard because often these are perhaps causing a small improvement, but sometimes it is hard to have enough patient numbers if you have a small improvement to get something called statistical significance. So you often need hundreds or thousands of dogs to be able to prove something works, which is then a real challenge. And because dogs, each individual dog is going to be slightly different, it can be hard to have lots of dogs who are very similar. So it can be quite hard in order to publish these studies using orthobiologics. And we can use them to kind of complement surgery. So we can do a surgery and then use stem cells as well. We can use them to kind of complement a rehab program. And also in terms of medically managing osteoarthritis, we can use them for that as well. There are a couple of other things that we can do with stem cells. We tend to do these a little bit less often, but you can use them in order to treat cartilage defects. So if you have a defect in the cartilage, we can take stem cells and we can process them in a very particular way that would actually try to encourage new cartilage to form. So if we had a cartilage defect, we can put these in. Then what we tend to do is use a glue, a sort of a fibrin glue that goes over the top of the stem cells to keep them in place. So they're keeping them, say, within a, I don't know how well you can see that with a light, but it's basically an OCD lesion that's here, that will then sort of keep them within that area. And we can actually then have new cartilage form. And we have done that in a few cases. The cartilage that forms is probably a bit more like not a perfect cartilage. It's maybe a bit more of a sort of fibrocartilage component. We can be able to refill over these sort of defects. So as well as in joints, we can also use stem cells to help with muscle and tendon problems. So again, these are going to encourage sort of tenocyte proliferation. So they're the cells that are within tendons. They can improve the alignment of collagen, can try to reduce fibrosis or try scarring, so try to have a bit less scarring, and try to promote some regeneration of muscles. So there have been some emerging studies showing some benefits in chronic supraspinatus, and there's also some studies about kind of gastrocnemius tears as well. So this is one of those studies whereby they were using stem cells and a combination of stem cells and PRP and injecting those for supraspinatus tendinopathies, so the muscle that's on the front of your shoulder. And what they were able to do is, as well as tracking the patients improving in terms of their lameness on a force plate, they were also measuring the size of the supraspinatus on ultrasound. And a little bit later on, I'll show you some examples if we've got time. But they could actually see that the swollen, inflamed insertion of the tendon was shrinking after having had the injections done. So that was quite cool. Now, what we've kind of talked about so far is patients having their own stem cells and their own PRP. You can actually take stem cells maybe from another animal and inject that. At the moment, we don't really have any studies in dogs. I think it can be done. It can be done. I don't know if there is any laboratories or anywhere in the UK that offers it, but I know elsewhere in Europe it's something that is available. What they kind of found in horses, there has been more research done in horses with regards to stem cells compared to dogs, is they started to find that some horses were kind of getting these sort of cytotoxic antibodies. And it may be that they were getting less effectiveness of the cell therapy because the body was almost sort of attacking the stem cells. And perhaps if they didn't get an adverse reaction on the first injection, they were maybe finding if it was repeated again in the future that they were having some adverse events. So that's one of the things I would just be a bit wary about using stem cells from other patients. In theory, if the stem cell is far back enough in its lineage, it should be okay because it should have less sort of or be less able to produce antibodies against it. But this is what some of the equine data is telling us. And then the other thing that is also available now is kind of stem cells in a bottle, which is stem cells from horses that has been licensed for use in dogs. So kind of nice in the fact it comes in a bottle. But again, there is potentially a worry about if you were using repeat injections, whether you might perhaps have an increased risk of side effects. At the moment, I don't think there is anything that's really published or talked about at all. It's not something that we've kind of used yet, but that is kind of one of our potential concerns. So particularly if we have a chronic condition that we want to use something repetitively for over a dog's lifetime, that this is only licensed to use as a one-off. So that's a potential concern. But yeah, so I think in terms of blood type, I don't think it's the blood type is the key thing, because I think it's because it's not coming from blood or not containing blood. I think it's less important about the sort of antibodies that would be then in the blood cells that causes potentially those reactions. So I don't think that that's kind of something that would have an impact in regards to their blood type. A very good question, something that you would kind of think of. So you kind of think of these reactions as maybe working in a similar way, but I don't think it's necessarily related to the actual blood type of the dog. And then as well as using stem cells for cartilage, joints, muscles and tendons, we can also use stem cells to help with bones. So this was a cat that had surgery done elsewhere and unfortunately had this large osseous kind of defect that formed. So what we were able to do is to custom make a plate, a pantarsal plate, that had essentially this kind of honeycomb mesh or network of metal. And we're able to seed that with stem cells. So it's kind of coated in stem cells. And then this was able to stimulate new bone to form and bridge what was a big hole and a gap in the cat's ankle. And then we're able to have this implant in place, and this was then able to grow bone all around it. The advantage is that metal can fatigue and break with time, but bone gets sort of stronger. So it's generally better if we can have bone bridging across rather than relying solely on the metal. So I think I've just got a few minutes kind of remaining, and I'll just try and quickly show you some examples of cases where we might use stem cells and PRP for. So in terms of osteoarthritis, as we mentioned in that kind of earlier study, the number one cause of us using them is for elbows. So it's typically a developmental elbow disease or elbow dysplasia. And if we have a fragment that we can go and remove with arthroscopy, we may still have wear to the cartilage. So we know we're not curing this condition, but we can then either use other forms of surgery to help, other types of medication to help. We can also use rehab and lifestyle changes to help. But something that we can also then utilize is stem cells or PRP. We've also had quite a few patients who have hip dysplasia. And they've been having PRP or stem cells to help with their hips. So one of our nurses, Emily, her dog has PRP to help with his hip. He's only got one hip. He's lost his other leg, but he's having PRP to help. And in terms of vet nurses, I know there's another vet nurse, and her dog got diagnosed with hip dysplasia at a young age, and she's been bringing him in to have essentially a top-up every year of stem cells in order to try to help keep his joints as healthy as possible. So yeah, we can use it for effectively any joint in the body. So any joint that has arthritis, we can use it for. The hock joint is also one we use it for quite a lot as well. In terms of muscle and tendon problems, so I mentioned to you about the shoulder and that study with regards to the supraspinatus problem. So if we have a look at that condition in a little bit more detail, the supraspinatus is, say, that big muscle that runs down the front of the scapula and is used to extend the shoulder joint. And what we find in dogs is they can get sort of repetitive strain injuries to that muscle, particularly it's where it attaches onto the humerus. See it really commonly in dogs with elbow problems. And my theory is they're trying to use their shoulders more to walk rather than pushing through their elbows, and they get these repetitive strain injuries. And after a while, the body almost starts to give up healing. There's no active inflammation anymore. And we can get this mineralization. So you'll sometimes take your radiograph and you'll see these mineralizations. Now, often these can just be an incidental finding and they're not actually that problem. So if you spot this on an x-ray, it doesn't mean it is a cause of lameness, but kind of examine that area well, palpate and put some stretching, some tension on that muscle by flexing the shoulder to see if you have a pain response. And what can be hard on, say, these obviously CT images, but on a radiograph, a medial lateral radiograph, you don't know where that mineralization is in regards to a medial lateral kind of depth direction. So if we were to look at this on cross-section, we can see that the mineralization could be in quite different places depending on which part of the tendon it is in. And the reason why that can be important is because where the yellow circle is, in that groove, is where the biceps runs. And what we can have is that bone bulging. So this is looking arthroscope image looking inside the shoulder. And this is actually bulging of the joint capsule where that piece of bone is pushing this forward. And just running down along this area is the biceps tendon. And you can therefore get impingement. And most biceps cases are actually the supraspinatus rubbing on the biceps causing the problem. These are then MRI and ultrasound images, and you get this bird's beak picture. And this is what they were measuring in the CANAP study, where they were looking at the size of this area, this bulge, and they were seeing that reduce in size with the stem cells and PRP. So with this image, you can see how the biceps and supraspinatus are in really close proximity to one another. And that's the bulging. And then this is inside the joint, and this is that biceps. This is where the biceps originates from. This is something that we can then get inflamed. And say the biceps runs up and down in this groove. So if we do have inflammation to the biceps, we can also get some new bone that can form within that groove. Just loading 1 second. There we go. Nope. And that can also cause inflammation. So if we have a supraspinatus condition or a biceps problem, we're usually going to start with something less invasive to begin with, and often find trying to sort of re-stimulate some healing to the supraspinatus insertion can be really helpful. So we'll often use something like PRP or stem cells. Also use shockwave as well, which is kind of ultrasound. It's trying to re-stimulate healing to an area. And we may then also use physio and potentially some laser. And only if that's not giving us enough of a good outcome, then we may consider going to surgery. And what we can actually tend to do a lot more now is we've now got the needle scope or the nanoscope. So this is a very, very small arthroscopy unit. So we can actually then do, say, shoulder arthroscopy, and that's our skin incision and that's our clip. So it's very, very minimally invasive. And whilst we are looking inside the joint and diagnosing some of the problems, we can also then use it as a needle and actually administer PRP down through the arthroscope at the same time. So it can be really useful for chronic muscle and tendon problems. And final one, we can also use it in kind of acute muscle or tendon injuries as well. So this was a nice little kind of, I suppose, learning example and kind of important to, whenever you see a dog, use your X-ray vision and think what's going on inside. So this is a dog that had a little cut over its knee. It fell in a river and was lame. And the local vets were able to clean up the wound, put a couple of little sort of staples in, but the dog wasn't getting better. And what had actually happened is that underneath that area where those staples are is the patella tendon. And these are the two stifles. And although there's a slight change in the angle of the joint, which can influence things, but if you look at the position of the patella, you can see how on this side the patella is maybe a bit further up the leg. And when we then have put on our ultrasound probe, we kind of compared the two sides. This was the patella on this side, and this is the tibial tuberosity. And this black band running across the top is the patella tendon. But on this side, there was this big disruption and a loss of continuity of that patella tendon. So we then went into theatre, and what we found once we opened up the knee was that the patella tendon had completely severed off its insertion point. It's all quite red on it. So we had this kind of complete severance of the patella tendon. So we did a repair of this and essentially sort of mimicked the human surgery using something called an internal brace in order to stabilize and support the patella tendon inside. And then also used PRP at this time. And when we saw the dog back for its follow-up exams to check on how the little temporary frame was doing and take the frame off, whenever we sedated the dog to do that, we're able to administer some more PRP to that area to help with healing as well. So as a bit of a summary, we can use these things to help many conditions. We can use it for muscle and tendon injuries, and we can also use it for joint problems as well. Generally, I suppose my recommendation would be to try to use it as soon as possible or as early as possible in the disease process. It's much more likely to have a more beneficial effect. The more severe, say, the osteoarthritis becomes, the less beneficial it will be. Many people tend to use other things, and if other things then aren't working, we'll often then perhaps go to stem cells as more of a final kind of Hail Mary to try and see if they can get an improvement. But I'd actually recommend incorporating it and using it into your management a lot sooner. And maybe perhaps before you start giving long-term medical management, so before you say, okay, let's have NSAIDs forever or let's have Librela forever, maybe try considering using stem cells and PRP at that stage. And it might be we can slow down the need for systemic medications that can have effects on the rest of the body and not need to use them so soon. So we can use them for many things. Can be useful to use them at the same time. If a patient is going into surgery, we can gather stem cells at that time, or we can use them in their own right. And again, particularly if we're thinking about osteoarthritis, we're maybe thinking about some older patients. If we do need to do a procedure to take a bit of fat tissue to do some stem cells, it might be useful to do that whilst they're still young, generally healthier, to undergo the anesthetic. And then we've got them stored, ready to use perhaps later on in life as well. Does anybody have any questions at all before we switch over? Yeah. Yeah, so people are watching this on the recording, just to repeat the question. Basically, the question was that if we are using stem cells and PRP together, are there any patients where we might use PRP to begin with, and then perhaps later down the line switch to both PRP and stem cells together? And there are cases where we do that. So sometimes perhaps if people are perhaps unsure if they do want to go ahead with the whole process of the stem cells and having a procedure to take some fat tissue and then coming back again, they might decide to try using PRP to begin with. Particularly as well, if we are just kind of diagnosing the problem for the first time and perhaps they've come to us, we've done some imaging, the patient is sedated and we have a diagnosis, it's very easy, even whilst they're sedated, to take some blood at that time and use PRP there and then. And we can see the effects of that. And if we are finding either it's helping or it's not enough to completely solve the problem, then they may decide to go for stem cells in the future to kind of repeat the sort of process. So the big advantage of PRP is we can just do it there and then fresh. It doesn't take too long in the centrifuge to spin it down. So whilst patients are sedated, we can kind of maximize everything we're doing at that visit. Generally, for all intra-articular injections, dogs and cats would need to be sedated. We generally can't do it with them sort of conscious. So it's quite useful if they're already sedated. We can try to offer them as many options rather than having to come back and forth for multiple sedations. Yeah. So the question was, is it useful in, I guess, in erosive polyarthritis? I guess if there is, I don't know if there has been much published on it that comes to mind. What I typically would say is if there is like an active process going on, so you've kind of got this active inflammation going on, I maybe wouldn't tend to use it there and then at that time. But if perhaps you've been able to sort of settle the immune-mediated problem, and then you've just got damage to the joint, you could consider perhaps using it for that. So that could be a possibility. I guess we tend not to see huge numbers of those kind of cases. So I don't think there is necessarily a case that comes to mind. Although I saw a dog today that potentially had a diagnosis of IMPA when it was younger, a few years ago, and now it has osteoarthritis, and they were actually considering using PRP and stem cells. So it's funny, that was actually this morning. But yeah, it's not something that's generally done a lot of to know. I think if you gave it at that time whilst they were experiencing a flare-up, whether it would be able to help or reduce the changes. But if you have had erosion, I wouldn't expect it to kind of regrow the joints, regrow the cartilage, I guess. Yeah, it's almost where I suppose that inflammation has done some damage and you've got that lasting damage. You could then use them perhaps for that. Yeah. Yeah, yeah. Yeah. So we can do, I guess, in terms of, say, if a dog came in and was completely otherwise healthy and we were sort of taking it for the possibility of using it in the future, I guess some people might argue, are you doing a small surgery when you may never use it? So is that ethically a good thing to do or not? But yes, you could use them and you could take them and store them. And yeah, we've got them that have been stored for 10 years or so, and they're kind of still, available, I guess. So, well, I guess in quite a while, we've been doing it for, I would have thought we've been doing it for 10 years now. I would have thought, I'm trying to think. It's been a while we've been doing it for. Yeah, been a while. Yeah, yeah, yeah. What have you got an idea of? Yeah. So question was, efficacy of the number of cells that we're using and the size of the joint as well, the number of cells that we're giving per joint, I guess. And this is where I really wish Anita, who is our mastermind PhD stem cell person, who's able to answer all these questions. But we definitely do have a certain number of cells that we're aiming for, that we aim to use whenever we're doing it. In terms of the size of the joint, in regards to the type of joint that it is, so small joints versus big joints, and also the breed of dog is going to vary in size. We can definitely inject different amounts of volume, but we're able to concentrate the cells. So even with a small joint, we can still get a very high concentration of cells. Just effectively, we put it into, for example, PRP, into some plasma. We can just change that volume, but the actual concentration of cells can be quite concentrated. So we can give a lot. But yeah, every dog will have it recorded, and it's so many millions of cells that we use. In terms of, are there studies that compare and say how many cells you should use? I think that's still, again, we don't know exactly the number that would be perfect, but we're kind of going on what we think is the best based on what we have at the moment. But I don't have the exact answer as to what studies are done. But yeah, I think we're usually generally aiming for around about the same amount, but we definitely can give more to some bigger joints. But I think we have to double check exactly what we do. But yeah, we do have it all worked out. I'm just not sure off the top of my head as to exactly what it is. But yeah. The answer is no. The question was, do we use it in LS disease, lumbosacral disease? Haven't done. There is a study using PRP for lumbosacral disease, but effectively what we really want to do is try to reduce as much inflammation as possible. So we often use steroids as a way. Yeah. So I'd be a bit wary of whether PRP would give you as good an effect at reducing inflammation, because the steroid is going to be so much stronger at reducing that inflammation. And because what we do sometimes see with orthobiologics more than other things we inject into joints, you can sometimes get a flare up of inflammation, because again, they do cause some inflammation. So I would be a little bit worried about whether if you got a flare up of inflammation in the LS around all the nerves, whether that could actually make things a bit worse. But people often come to us saying, the dog has a spinal problem. Can we inject the spinal cord with stem cells? And, no, we can't do that. But you will have seen various stories in the media where people have kind of had that done. So there may be amazing things to come, but it's not something that we're kind of doing at the moment. I don't think anybody's necessarily doing that in clinical dogs patients. But did you have another? You think you said you had a few, didn't you? Or?
Yeah, I mean, I have actually
Uh-huh. With PRP or? Okay.
Yeah, my other question was
No. Yeah, no, not that I know of. Definitely not for any of my cases, and I don't recall Anita or Rosie mentioning that they didn't have. We've had some cases where, particularly say in a couple of older dogs, whereby to get the number of cells we need, it's taken longer. So we've had to culture them for longer before we freeze them. We have had that before, but we're always able to get enough. And yeah, in terms of defrosting and using them, we've not had that as an issue yet. It might be that it helps, yeah, in terms of not having to worry about things in transit. It's just down the corridor rather than across the country. But yeah, I guess they probably knew in the laboratory before they sent them to you that they hadn't been able to grow them, I guess, so you kind of already knew then. But yeah. Yeah. Not that I can say that is enough of a difference for me to notice, yeah, whether we've done it, say, within those fresh cells a few weeks later or 2 weeks later versus years down the line. I wouldn't say that I have done. I guess the only caveat to that perhaps is that, again, if we're doing it years down the line, the condition has got worse over those years. So the osteoarthritis has got worse. So perhaps do you have dogs whereby initially they seem to be responding well, and then as time has gone on, you're getting less of a response? Definitely I've kind of come across that. But I think that's usually more the condition getting worse rather than the cells being less effective, has been my thought for that. Yeah, Rod. I guess in terms of using it to like help a fracture to heal, I suppose. I mean, um, I guess that is all going to depend on. It's going to be affected, just like all the other. I'm guessing it's going to be as all the other cells are affected by this the strain and the forces that are there. Those cells will affect the cells around to try to help them to encourage kind of healing or kind of bone to form. I guess, yeah, if you had a construct that was very unstable, that wasn't conducive to kind of bone healing, then again, they're not going to be able to heal or form new bones. So I think it's going to be exactly the same as the cells that are there. So I don't think it's a case of we inject the stem cells and they're necessarily going to go to cartilage or to bone. I think it's going to, yeah, just be like all the other cells that are present, I would have thought. But in like a natural situation. Yeah. So if I can think back, it's all to do with the electro forces, I believe, between the cells. So it's kind of like there's almost this little electricity kind of current that's forming, and the amount of force that's there, that is what then stimulates the bone or the cells to start off as being cartilage and then transition into bone depending on those forces. It's kind of how they're connected. I think it's something to do with that, but yeah, it's kind of quite deep pathophysiology to think about. Yeah. Yes, yeah, we do often joke about it. Actually, we see a dog with a lipoma, we think, oh, that'd be great for stem cells. I guess that we've never done it, and I suppose the potential worry is that lipoma going to be neoplastic, and therefore is there a potential that you could spread that, or could any stem cells have a potential neoplastic problem? So one of the kind of a natural kind of growth factor in the lipoma. Yeah. So that's, I suppose, one of the kind of contraindications for using stem cells would be patients that have neoplasia, because there is a worry that they might then speed up the neoplasia or the cancer. So although you sometimes see this nice blob of fat that would be kind of perfect to take, we haven't done it. And I guess that's our worry about it, is that whether we would potentially speed up any tumor or cause a spread of tumors or something along those sorts of lines. So yeah, we often joke about it, but we haven't done that. Yeah. Yeah. So that's another good question. So again, there are some studies that were done that seem to suggest that things like non-steroidal anti-inflammatories would perhaps reduce the effectiveness of PRP and stem cells. And there's not a set defined thing. So if you look at kind of what's done in humans, some institutions will recommend that people don't take NSAIDs afterwards. Some will actually have you stop NSAIDs weeks or months before they take the blood for the PRP. There was then a study done in dogs, whereby what they found, perhaps in Sam Franklin's study, was that there was no negative effect for dogs who are having PRP having NSAIDs, and it didn't affect them. So whether it's different for the species or the type of platelets or the stem cells, or whether it makes a huge difference, there's not something that's like well set in stone, this is what you should do. Normally what I tend to do is that if patients have had PRP or stem cells, is try and stop NSAIDs for at least maybe a week or so afterwards, when those cells are starting to have their effect. A lot of the time, patients who come in perhaps are already on non-steroidals, and I don't necessarily send them away and get them to come back weeks later to suddenly have a PRP injection done. But yes, after they've had it, we'll try to hold off NSAIDs if we can for a week or two, give them a different form of analgesia instead, often something, say, paracetamol based. Take things gentle with exercise for a week or so afterwards, just in case there is any post-injection soreness. And if they're also then dropping down their non-steroidal, we'll just take things a bit more gentle following that. And then potentially can then sort of restart it if it's needed, based on how severe their problem is. And in terms of the benefits, again, with things like PRP and stem cells, they take a little bit of time for those cells to start to have an effect. So it's not we inject, they wake up, they're suddenly better. It's usually maybe kind of say 2-3 weeks or so after injection is when you're more likely to see improvements clinically. Things like steroids, if we inject those, you often see an improvement a bit quicker, often within a few days or so. So that's something that's slightly different between them. Perfect. Okay. We've done a few, not lots. We have done. I think it's only a small number, like a handful, a couple of handfuls, so not lots, but we have done with them. Yeah. I'm trying to think if I've actually done one. I'm not sure if I have had a cat where I've used it for me to be able to say that this is what I've seen. But I think we have done a few, but not a lot. Yeah. Have you done many or any? Oh. Yeah. Okay. Perfect. Okay. Oh, one more. Yeah. Yeah, yeah.
If by and large everyone is using PRP alongside the stem cells, how come none of the studies say that?
Well, some studies do show both. So the Knapp shoulder study, they use both. I guess the potential challenge is lots of the time people are wanting to show, say, are stem cells having an effect? If you add something else in that may also be having an effect, it's then hard to then have a conclusion from that study that the stem cells made a difference, because it may have been that the PRP made the difference. So what you might need to then do is have cases who just have PRP, cases who just have stem cells, and those who have both, and then compare them. That would be the ideal, lovely thing to do in a world where you could kind of design your own sort of study. But that's probably one of the reasons why, because if you're adding in an extra variable, then it can be a conflict with the results, and it'd be harder to kind of draw conclusions from it. But yeah, some studies will use the two together, and that's what they will set out to see, do the two together help. Perfect. Okay, so I think we're going to take a little break for 5 minutes.